evening all to the 85th session of the Weekly Huddle. I'm Anoop and joining me today is Praneeth. We are cardiologists at Care Hospitals and we have been doing this Weekly Huddle program for just short of 2 years now. This is our 85th session and we are going to talk today about something which can be very clearly considered as the very first chapter of cardiology, as in the basics of cardiology 101. This chest pain business is something that comes across every specialty, and pretty much every single practicing clinician has to deal with chest pain in one or the other form. Obviously, with physicians and cardiologists facing most of it because of the concerns for coronary artery disease and acute coronary syndrome. So I welcome you all on this 85th session. You all are quite familiar with the format of the Weekly Huddle. We discuss a case and the scenario around it in a very informal fashion. The idea is to get our casual hallway discussion into a little bit more organized platform like this one. While we do want to talk about guidelines, with this huddle, our main intention is to help a physician translate what is established knowledge to how we practice medicine in the Indian context, particularly taking local factors into account. This is not a speaker and an audience model, which means if you do have any thoughts or questions, you can either share with us on the chat box or raise your hand and you'll get a chance to speak up regarding your thought or your question. So with this brief introduction, I'll start with today's case. As a customary, I ask my colleague Praneeth for his initial impression, and then we will go down our attendees list for their opinion about this case. And truly speaking, it's been quite a while where we discussed a topic which is directly related to cardiology. So apologies if today's discussion becomes a little bit cardiology heavy, but I think this is a very important topic for us to discuss. One of the reasons why what prompted me to discuss this topic is because of a recent published guidelines by ACC/AHA. I believe it was published last month, which was a very exhaustive guideline describing how to manage chest pain in inpatient, in emergency, as well as OPD setting. One has to understand that guidelines are guidelines. They are not holy grail. They are, as the name speaks, they guide us towards decision making. They are not something that we have to absolutely follow in a religious fashion. So having said that, this is the case for today. I saw this patient last week, but I'm going to put it up as if I saw her today. This is a 52-year-old female. She's post-menopausal. She actually stays around 100 kilometers away from Hyderabad. And at home last night, she woke up from sleep. This happened at around 2 o'clock in the morning. She got up because of chest pain, which she describes as substernal. She really cannot pinpoint where it is, but she tells me that it is in this area. And this pain was described as dull aching pain, which lasted for a few minutes. And like what would happen, she got up, she walked around, she got herself half a glass of water. And after a few minutes, she felt okay. So she went back to sleep, only to have the symptom recur after 4 or 5 hours. That's again now at around 6 o'clock in the morning. And this time also she got up, she walked around for some time, and because it was morning, she didn't go back to bed. And this pain syndrome lasted for a few minutes, probably somewhere between 5 to 10 minutes. After that, she had been doing okay. She decided to come to Hyderabad. This is where her cousin sister lives. And now it's around noon time when I'm seeing her. She's otherwise feeling fine. She has got a past history of hypothyroidism, for which she takes Thyronorm 75 micrograms daily, and her TSH, which has been checked last month, is pretty good. She does not have any other associated symptoms on open questioning. When I started questioning her with direct questions, then she vaguely mentioned that in the first episode of chest discomfort, she may have experienced a little bit of sweating, but other than that, there was no any other associated symptoms. She didn't have any of these symptoms previously. And for her routine activities, she's reasonably active. She's a teacher, although she has not been going to school lately. She does do online classes. With her level of exertion, she never had chest discomfort or whatnot. She does not have any obvious coronary risk factors in terms of comorbidities or family history or behavioral patterns, whatnot. Her physical examination was unremarkable. Her blood pressure and pulse rate during the OPD visit was also normal. She's a vegetarian by diet, and her diet pattern had more or less been pretty standard. By the time she came to me, she actually had an ECG and echocardiogram done from outside. This was suggested to her by her cousin to get it done before she meets me. And her ECG and echocardiogram were within normal limits for her age. She didn't have any other blood work on any other tests for me to review. So the points that we are trying to discuss is, I gave you a picture of a 52-year-old female with no obvious risk factors for coronary arteries, except if you consider her age being postmenopausal, although at 52 female, we would still consider it as a premature coronary artery disease. Other than that, there isn't really in the risk factor that I could see. Who has this chest discomfort, again, which whether it has got a typical component or not, I leave it on to you for assess, who comes here with a normal ECG and echocardiogram. Are we done here in terms of coronary artery disease, or does this patient need any further workup? Are you going to write her off saying you are fine, go home, or you want to work her up further? And if you do, what would be the next set of investigations? And then once we are done with this patient, then I want to discuss about two things in particular. One is how to use these ACC ESC guidelines in Indian context, particularly understanding that the guidelines are written for Western subset, both in terms of the practicality of it, the availability of the investigations, and also the cost effectivity analysis, which of course is different for Western world as compared to India. And then the last, which is probably the most important aspect, tips and tricks on how to handle, how to balance this conundrum of over versus under testing. Because as a cardiologist, I always struggle whether I'm over testing somebody or whether I'm under testing somebody. I don't want to miss coronary artery disease, but at the same time, I don't want to over test every single person in my attempt to not miss any coronary artery disease. And that conundrum also, I believe, is a daily issue for any practicing cardiologist. So Praneeth, I hope you got the question. I have her case absolutely fresh in my mind. So if you do have any questions about the case, please feel free to ask me your impression on this and then the questions that I put up for discussion.
Yeah, I believe her ECG was normal enough.
Yes, her ECG and echocardiogram, both are normal.
Yeah. Yeah. So the way I look at this patient, relatively young lady with the new onset chest discomfort, which never was there, a new onset chest pain. So coming at unusual time, like in the middle of the night, she getting up with the chest discomfort and kind of getting better. The symptoms, the way you described me, it looked like a description of a paroxysmal nocturnal dyspnea for me, or at least a P&D equivalent if I have to put it. So I would consider this as significant. Probably a close differential could be something like a nightmare also, or a bad dream, but the points which makes me consider more like a cardiac event because of the repeat event which happened after a few hours. So I would definitely consider this patient to be having this as a cardiac event or as a serious event. And I would, of course, the regular labs, what you said was about ECG echo is being done to basic things, but I would consider this as an event of an unstable angina. And I would recommend this patient for further evaluation of coronary artery disease in the form of an coronary angiogram. Now, depending on the how the patient takes it, I would definitely consider doing an invasive angiogram. But if she's apprehensive or whatnot, I would advise her to get at least a CT coronary angiogram to look at the coronary artery disease. Now, when we talk about angina, it could be because of epicardial coronary arteries or equally because of the microvascular angina that she can have. Because again, being a woman, the possibility of having endothelial dysfunction and having microvascular angina is also quite common. So what I would like to look in angiogram is whether she has any epicardial coronary artery disease, significant stenosis, which can end up having an acute coronary syndrome again. And equally trying to see whether she has any slow flow or whatever. But for this patient, I would definitely consider this event as an unstable angina, and I would warrant an angiogram and go aggressive. Your question on how aggressive to go or undertreat versus overtreat, I look at what is the cost of getting an event if it is being missed. So younger the patients are, a bit more aggressive I will be. Women again, because the atypicality of symptoms are there, and if there is any slightest hint, I would be again try to rely more on investigations, because the regular investigations in her case in a women will be not applicable like a treadmill, etc. So I will be again tilting more in terms of doing a definitive investigation in the form of angiogram for a woman, where I do not want to be sorry missing a problem and she ends up having an event. Versus someone who is elderly, limited physical activity or whatnot, again not getting biased, but maybe I will be less aggressive in them. Versus younger patients, I would be trying to be a bit more aggressive because I do not want to miss any event. Regarding guidelines, as you mentioned, they are there. I think we should all have a look at it. Apologies that I did not go through the current guidelines, but I believe all the practicing physicians bar cardiology should have a look on the guidelines and see or get what is relevant for their practice and use them to see what makes sense to apply in their clinical practice, but not go directly. Most of the investigation they rely on their setup, where emergency patient coming to chest pain with emergency doing a CT scan or doing proponents, etc., which are limitations in our setup because those CT scans are there and it can be done. There is nobody to report, and sometimes troponins are not quantitative; they are qualitative, etc., which may be falsely positive. So those things, depending on the situation, we should probably adapt and apply in each and everyone's clinical practice. So this is my take on this patient turn-up. If there are any questions, I would add.
Okay, Praneeth, see, I hear what you are saying, and 2-3 things about your answer that I want to highlight, and then I will go to Chandramukhi ma'am for her opinion. You mentioned about being aggressive in young guys, and this is the young conundrum, the young paradox that we have, that young people are the one where the pretest probability of coronary artery disease is low, but these are the same subset of patients where the price of missing a coronary artery disease may actually be very high. So it's like we are trying to fish through a low risk subset, but understanding that if they do have an event, if you prevent one event in a younger individual, that has got a much better value, or whatever you call it, in that regard. I still struggle to talk to patients, particularly low risk patient, about a direct invasive angiography when I find no objective evidence of ischemia. And I understand that at times we go by our clinical judgment and gut feeling rather than objective evidence. And this is where I think cases like these, they make it a little bit difficult to see how we approach. Chandramukhi ma'am, you heard the case, you heard Praneeth's opinion. How would you take up this case? This is a 52-year-old post-menopausal woman who had this chest discomfort for the first time. If any part of history you missed, please let me know. I will repeat that. Chandramukhi ma'am, I hope you are able to hear me.
Hello, good evening, Anoop.
Yes, ma'am. Please go ahead.
Yeah, I heard about the history of this patient. So, like as Pranit has already mentioned that this patient has symptoms at very unusual time, and I will also give importance to her symptoms in the night. So, though the pre-test probability, like if I want to do treadmill test in this patient, the pre-test probability will be very low in her case, but I would not like to neglect the symptoms and just give her a clean sheet that because the ECG and other investigations are normal, nothing to worry. I would like to investigate further. So in this case, because the patient had symptoms the night before, so I would like to do troponin I. If troponin I is negative, then it is very specific that it was not acute coronary event, because the ECG was also normal, troponin was negative. Then I would like to do treadmill test in this patient to rule out any coronary artery disease.
Okay, ma'am, I like your idea that we do more investigation or investigate a little bit more to be more objective in terms of what we are looking at. So doing like a high sensitivity troponin could be a gatekeeper for us to say that, okay, if it is positive or even if it is higher, because in her case, I would expect a high sensitivity troponin to be undetectable, not just at the higher end of normal. I would expect it to be absolutely normal. So in her case, if high sensitivity troponin is even on the higher side or frankly abnormal, either way, that can give us kind of a gatekeeper assessment that, okay, now it makes more sense to go for an invasive angiography or a CT for that matter, versus if it is completely normal, then one can argue to go for a stress test, like in your case, you mentioned treadmill test. Ma'am, my question to you, 52 female treadmill test, we have all read this since our MBBS days, that TMT has got high false positivity in females. You see it day in, day out. What is your impression? You think TMT is bad for women, or we should do it? We should do it.
Actually, in this case, as I already mentioned, that the pre-test probability will be low in this case, and the ECG is normal. So though we have false positives in women, but ECG is normal at baseline, then I would prefer to do treadmill test in this case, because already you mentioned that the patient has come for the first time with some symptoms in the OPD, and she did not come in the night. If she had come to the emergency in the night, definitely I would have preferred some other modality of investigation like CT coronary angiogram. But because she has come to the OPD, and if the troponin is normal, then we can safely do the treadmill test. If troponin is high, she will be at the directly go for invasive investigations. If the troponin is negative, I will definitely like to do treadmill test, because the ECG is normal. At least we should have some idea regarding the coronary artery disease. In addition to that, I would also like to do the lipid profile to check her LDL levels, and also HSCRP levels, which will also give us an indication about the coronary artery disease.
Thank you so much, ma'am. I think that these points are to be noted. So I believe one of the reasons, so patients coming at night, that's a very good clue for us to understand the severity of the problem. I believe one of the reasons why this patient didn't come at night is because she lived far off. I didn't ask her this, but if she would have been a local resident, my guess is she probably would have come in the night itself. But again, that is my impression. It doesn't have to be true. Your idea of going through HSCRP or lipid profile and all this to establish her risk profile, that is very important if we are not going for an invasive angiography directly. And I think these are points which are absolutely well taken, that even if we don't want to explore in an invasive fashion, nobody is stopping us from doing further risk profiling of these patients. And based upon their newer risk profile after the labs are back, we can make further decisions about what to do and what not to do. I think these are absolutely well-founded ideas. One thing that I do want to mention about this whole high sensitivity troponin business, it differs in different labs in terms of its cutoff value. So I urge all of you to look into your lab and see what is your cutoff. And I'm talking about high sensitivity troponin, not the routine troponin, definitely not the qualitative troponin. The reason why it is important is because high sensitivity troponin has a normal range. Like in our lab, the range is anywhere from 0 to 17. And in patients like these, if she gets a number of 15, 1.5, while 1.5 will not trigger an abnormal value, for me, it is still abnormal because I don't want her to have a detectable higher level of troponin. Her high sensitivity troponin should be undetectable, should be 1, 2, 3, it should not be 15, 16. These are the kind of assessment that a that a regular troponin won't be able to do, but a high sensitivity should be able to do. A person who is 65-year-old, who is very active, particularly if the sampling is done after a bout of exercise and all this, there I can expect troponin to be slightly on the higher side. Certainly not more than 17, by no means, but still 14, 15, 16, these kind of numbers can be expected, particularly patients who are on dialysis, who are at the extremes of age and whatnot. But for patients like her, anything other than undetectable troponin can be considered a red flag as a risk marker for coronary artery disease. Ma'am, one last question that I have for you, and then this question I'm going to ask to my other attendees as well. This is outside of today's discussion, but the topic is the same. When we talk about pre-test probability of coronary artery disease, and when we say low risk for pre-test probability, ma'am, in your opinion, in your practice, when you say that you have a low risk for coronary artery disease or low risk, low pre-test probability for coronary artery disease, what is the number you are looking at? Like below what percentage you say it's a low risk for coronary artery disease?
Anoop, I would like to consider the various risk factors for coronary artery disease, like age in women less than 35, in men more than 45 years, then family history of coronary artery disease, the lipid profile, any like habits like smoking and alcohol intake, and any so these should be the risk factors which will tell us about the pre-test probability. If the pre-test probability is low and the ECG is normal, then I would prefer treadmill testing.
So my question was this only: when you say pre-test probability is low, like what is the number? Like I'll give you, for example, when a person comes to me for a pre-operative cardiac risk assessment, and if I write that your cardiac risk in this surgery is low, what I mean is you have less than 1% chance of cardiac event during the surgery. So when you say somebody has got low risk for coronary artery disease, what are you implying? What is that low? Is it 1%? Is it 10%? Is it 50%? What are you implying? I just want to understand your thought process.
Exactly the exact number, to be honest, I don't know the exact number.
Okay, we will continue our discussion, and my request to the attendees is if anybody wants to add or put any questions for today's discussion, please raise your hand, or you can unmute yourself and share your thought while I continue my discussion with the rest of the attendees. So Dr. Shankar, if this patient was to come to you, let's say in your setup, had these episodes in the morning, ECG echo is normal, she comes to you, she's feeling comfortable, how would you take up this case?
Good evening to all. The evaluation of chest pain in a woman is a paramount importance because CVD is the leading cause of mortality in women. So here, when the same patient comes to me, because of my experience, most of the times I say that it is a case of peptic ulcer disease or reflux esophagitis or the esophageal spasm, because many of the patients they come to me even in the night also when they get retrosternal discomfort. So here the reflux esophagitis, peptic ulcer disease, esophageal spasm, the functional gastrointestinal disorders all will produce a substernal pain. it may be suggestive of angina pectoris, it mimics, but in my opinion, it is a case of reflex esophagitis with diffuse esophageal spasm. So when the patient comes with the substernal pain and the recumbent or supine position, probably it may be aggravated by a large meal or the late night meal, might be spicy food. So that regurgitates into the esophagus and produces a substernal pain. And here, this got relieved by water. So that indicates that it diluted the acid which is regurgitated into the esophagus. So she got relieved and she slept, and again she had, because in the morning also there will be the acid surge will be there, and she might have had this reflux esophageal disease, esophagitis. So having known that this aggravating factors and the relieving factors, I strongly consider it is a case of reflux esophagitis with esophageal spasm. But however, with the pretest probability, taking into consideration age, sex, and history, it falls into the category of low to intermediate risk, because she has got atypical angina. So a 55 years woman with atypical angina, definitely she has to be investigated further to rule out coronary artery disease. So low to intermediate risk group, they should undergo non-invasive stress testing, especially here, because the ECG is normal and HS troponin normal, then exercise ECG 20 to 50% of the times it may be false positive in women. Then I go for, that's why I avoid exercise ECG in this case, and I go for either stress echo or stress thallium. But if stress echo shows regional wall motion abnormalities or stress thallium shows then perfusion defects, then I go for the invasive angiogram and proceed that way. But if all these come negative, if the stress thallium comes negative, then I go for endoscopy, H. pylori testing, and esophageal motility studies, and further strengthen my diagnosis of reflux esophagitis with a diffuse esophageal spasm. Thank you.
Thank you so much, sir. A lot of points you brought up. The first and the foremost point that I want to re-highlight from what you said is the most likely diagnosis in her case, and I'm saying most likely because statistically that is what is happening. The most likely diagnosis in her case is upper GI abnormality, either in the form of gastritis, either in the form of gastric reflux, or in the form of esophageal spasm or whatnot. In all likelihood, that is probably what is happening. And I think that you highlighted absolutely perfectly. What you also highlighted, and I think that point is well taken, is while gastritis becomes our differential, we have to make sure we are not dealing with a coronary mimicker with a reasonable sense of surety. Of course, we shouldn't be doing angiogram left and right on every person. But even when gastritis or gastric reflux becomes our differential number one, we have to make sure that we are not getting fooled. And that is where I think the role of cardiac investigation first comes into play. And only when we have a reasonable surety that the patient does not have an active cardiac problem, then we address towards GI symptoms and whatnot. So I think this point is absolutely well taken. You mentioned about the TMT and stress echo. And what Chandramukhi madam mentioned, that TMT can be done in these subset. what you mentioned is very relevant, that historically, what we have realized is there may be higher incidence of false positive in women. Although there is a newer data set, newer pooled analysis, which is coming up, which suggests that our initial thought process of, or our initial observation of TMT being more false positive in women may not necessarily hold ground. With our enhanced or our updated protocols of defining what is positive and what is negative, the gender-based difference of TMT versus other stress modalities are or don't seem to be any more relevant. You mentioned about stress echo. One thing that I do want to mention to the audience here is that stress echo, at least in my lab and what I have seen in India, is not a physiological stress echo. Most of the stress echo that I see being done around is a dobutamine stress echo. The labs typically are not equipped to do exercise stress echo, which is the more physiological way of doing it. So whenever we send somebody for a stress echo, we have to understand that there is a very high likelihood this patient is going to get a pharmacologic stress echo, that is dobutamine, as compared to physiological stress. And as we all know that when we talk about stress testing, then physiological stress is always better as compared to pharmacologic stress. So those were the points that I wanted to highlight, sir. Thank you for bringing up the gastric issues. I'll continue my discussion with the rest of my attendees. Anybody has got any thoughts or any suggestions or comments about what we are discussing? Please feel free to unmute yourself and share your thought. And while you do so, I'm going to read some of the comments which have been put in the chat box. So Santosh writes, pretest probability takes age, gender, and symptoms into consideration, but how to adopt it when patient is having risk factor like diabetes, post-menopausal, etc., which are not taken into account? Santosh, I totally agree with you. When we talk about the newer modalities of pre-test probability, they don't take diabetes status or risk factor status into account. I totally agree with that. The only thing they take is gender. They take symptoms, which is chest pain versus dyspnea. And the third thing they take is gender, age, and symptoms, which is chest pain versus dyspnea. They don't take anything else. But I have a problem with this pre-test probability to begin with. And this is the question that I discussed with Chandramukhi ma'am. If you look at the guidelines, and I'm very interested in hearing what my attendees think today. Maybe I'm overreading it. If you go by the guidelines say that any person on whom you have a pre-test probability of obstructive coronary artery disease less than 15%, 1.5, that can be classified as a low risk patient or a low pre-test probability for coronary artery disease, and those patients can be treated as a low risk algorithm. While the data set is looking at a population wide and a generic statement or whatnot, I have a problem. I don't know how many cardiologists would agree with me, but in my OPD practice, if I work with a pretest probability cutoff of 15% as low risk, then I will be missing a lot of patients who come into my room with coronary artery disease. That means every 100 patients whom I evaluate, if 15 patients, I discount them by saying they have low risk probability, I'm missing those 15 patients. To me, it seemed like a low risk pretest probability would be less than 1% or less than 2%. I don't know how patients would react if you tell them that your pretest probability is 10%, which is considered low, so we don't need to do any further investigation in you. So the answer to your question, pretest probability does not take these things into account, is absolutely valid. Even if they would take into account, their cutoff is 15%, which to me looks very high. To me, a pretest probability should be like a 1 to 2% as a low risk. Anything more than 2% or 3%, to me, sounds like that's too much. I cannot miss that many cases in my clinical practice. That is just my impression. The second question, which is there in the chat box, is the treadmill test gives a score for coronary artery disease. If you could tell us more, I think this is a question that Chandramukhi madam is more equipped to answer. Ma'am, if you could please unmute yourself and share with us the treadmill score. I believe she's talking about Bruce protocol, and she's talking about a Duke treadmill score. If you could just brief us about what the scoring is and how do we analyze them. Chandramukhi ma'am, if you could please share that. Ma'am, you are still muted. You need to be unmuted. Okay, maybe there is some technical issue. Anjini, you want to take this? Dr. Anjini, she is a consultant working at Banjara unit. Okay, we'll come back to this question for sure. If there is any other questions or comments, okay. Pardasadi writes, heart score and TIMI score will help in risk stratification. Okay, so let me get that confusion out. Heart score and TIMI score, they are two different things. They're totally two different things. Heart score is for asymptomatic patients whom you are trying to predict your ASCVD event risk in the future. So heart score is like your Framingham risk score. And that is for asymptomatic patient. That's a risk stratification for future events. TIMI risk score is what you do when you have a patient whom you have diagnosed unstable angina or NSTEMI. And the TIMI risk score is going to guess their 30-day mortality in hospital. So TIMI risk score is for acute setup. Heart score is for risk stratification of future ASCVD event over 10 years in asymptomatic individual. What we do in treadmill is a Duke treadmill score, which has got a negative mark. And the more negative you are, the higher the risk it is. And once Chandramukhi ma'am is online, I'll have her throw some light on it some more. One of the questions that comes is, what are the points we use to base the pretest probability? So pretest probability, Dr. Balaji, takes three things into account: age, gender, and the kind of symptoms, which is chest pain versus dyspnea. And it's a very simple algorithm. It is a table, 2x2 table. You just look into it, and any number that is less than 15%, guidelines would characterize it as low risk, and anything more than 15% over a continuum of 100%, they will characterize as intermediate risk or high risk. And this is the question that I have, or a point I need to pick up, that 15% to me is too much. For a cardiologist, it is too much. Maybe for a general practitioner, 15% may be okay because they are seeing a wide spectrum of patients. But for a patient to enter into a cardiologist office, cannot be satisfied by saying that there is less than 15% probability of them having coronary artery disease. To me, that number has to be 1 to 2%, not more than that. Okay, anybody else has got any other questions or comments about today's discussion that we are having? Okay, if not, then maybe I'll invite Dr. Somaraju a little bit early in today's discussion, because this is relevant cardiology topic. Somaraju sir, how do you look at this particular case? Would you do anything on this patient? And how do you, or what would you tell us in terms of risk stratifying these chest pain patients, not the asymptomatic patients?
Good evening, everybody. Thank you for asking me. And I must say first, chest pain is one of the most difficult symptoms to evaluate. Even after you spend 30, 40 years or more even in cardiology. So it's a difficult symptom. Let us accept it first. And secondly, having said that, mistakes occur. Mistakes are quite common in the practice of, say, evaluating chest pain, both in emergency as well as elective. Having said that, coming to this patient, hypothyroidism is a risk factor for coronary artery disease. And having said that, I just want to check only two things before you go further. Number one, is there anything to suggest obstructive sleep apnea in her? Number one. And number two, is there a family history of diabetes? Was HbA1c done? The other thing I wanted to also emphasize is, when a patient came to you chest pain previous night or the last few days ago, I will never do an exercise test in such a patient because you don't know what you are dealing with. Exercise test is risky. I know patients who had myocardial infarctions on the exercise treadmill and even death occurring. And published evidence on safety of exercise test is not reliable because you have to categorize your patients. You go on doing exercise test for all non-cardiac chest pain patients, everything looks very safe and all that. And also another issue that you have to also keep in mind is post-menopausal women. We should not categorize them as women were tests in women. They come under a different category altogether. They are almost like males, unless the resting disease is abnormal, etc. Interpretations will be more towards what we do routinely than say that she is a female. And if how to deal with this person, if there is no obstructive sleep apnea, if there is nothing to suggest anything else, I still want to rule out coronary artery disease in her. And she doesn't live in Hyderabad. She lives far away. Actually, there is one study which was conducted some time ago as to the people where they live and their health status and longevity, etc. People who live nearby to a good hospital with all the facilities available, they did better than people who lived far away from a good hospital. So she lives far away, and she has to be, we have to rule out coronary artery disease in her. And then depending upon the nature of the pain and other issues, talking to the patient directly and other risk factors, as I suggested, I will still want to rule out coronary artery disease in her. I will want to do a CT coronary angiogram on her before I ask her to go away, far away from Hyderabad. Thank you.
Thank you so much, sir. I'll unpack some of the things that you mentioned. First, I'll answer your question. So, based upon the history, I did not suspect that she was having sleep apnea. As you know, and audience knows that over the last few sessions, we have been quite particular about screening for sleep apnea. And me and Praneeth, we both are quite aggressive at it. And I, in this particular case, did not suspect her to be having sleep apnea. I did not order that test. HbA1c at the time of assessment was not available with me, but I did order it. And just to complete the scenario, I will tell you her A1c was normal, 5.8 was her number. And then family history of diabetes, she didn't have. She could not recollect anybody in her immediate family who had diabetes. There were distant relatives who had diabetes and some had hypertension, but there was no really early disease risk factor in her immediate family that I could answer. Now, one other important aspect that you mentioned about stress testing, and this is again something which I want to highlight to this audience, particularly my non-cardiology colleagues who are attending this session. Whenever we are dealing with chest discomfort, we have to look from the aspect of what is happening inside the coronary arteries. And a patient who comes to us with exertional discomfort or whatnot versus patient who come to us with one of a kind chest pain, they are two different substrate or two different spectrum of patients that we are dealing in terms of what is happening with the plaque pathology or the coronary pathology. Whatever we talk about in terms of risk analysis, pretest probability and whatnot and all this, they are mostly defined for stable symptoms. They're mostly defined for those patients who have got stable symptoms. And what are stable symptoms? these are the patients who never had resting discomfort. They always have exertional discomfort, and they have what we describe as some of those typical features of angina. They may not have all the typical features of angina, but they have so-called stable symptoms. And there we do risk assessment, there we do treadmill and all these things to address or to analyze how much of disease they would be having, or whether they would be even having disease to begin with or not. Versus we have got cases like these. It is very clear at her resting state otherwise and during exertion, she does not have any symptoms. Her symptom is one of a kind. So if her symptom is coronary in nature, by definition, it's an unstable coronary syndrome. By definition, it is not a stable coronary syndrome, provided it is a coronary symptom. And that is what we are trying to understand, whether this is a stable, whether this is a coronary syndrome or not. If it is an unstable coronary syndrome. And in an unstable coronary syndrome, we have to conclusively prove that there is no any active cardiac damage going on, either in the form of serial ECGs or in the form of biomarkers or in the form of whatnot, before we stress her or do anything. Because if it is truly an unstable coronary syndrome, stressing her directly without knowing what is going on in the heart can actually be detrimental. This is completely different than those stable patients who come, who say, I'm having chest pain for about 3 months now or 1 month now, and I don't know what this is, with a normal ECG and echo. There, you are allowed to stress them and do whatnot. But these kind of patients, it's a little bit of a problem. Now, I do want to highlight one more thing, what is mentioned in the chat box. Praneeth and Santosh, they both have shared the charts for pretest probability. And I want to correct that. The charts which are shared here, please do not follow this one. This is the old school Diamond Forestier classification, which we all studied during our MBBS days. In fact, the pretest probability algorithm has been redefined multiple times since the original Diamond Forestier classification. And I suggest you guys to just Google it or go to the recent chest pain guidelines. It is all over the place. There are newer algorithms which give you a better estimate of the pretest probability. So the chart looks exactly the same. It is the same age, same gender, and same chest discomfort versus dyspnea, but the numbers are different, and those numbers are more calibrated with the current context than what originally Diamond and Forestier classified. I personally like the Diamond Forestier classification more because it was a little bit more aggressive. It allowed us to test more patients, but and I believe the current approach is a little bit more conservative. I keep coming back to this 15% pretest probability, which in my opinion is just too much. I don't think that we should be looking at 15%, but then who am I? Because there are international guidelines which put a cutoff at 15%. One question which is there in the chat box is, what's the latest guidelines on Prinzmetal angina? You know, I don't think there was ever a good algorithm to diagnose Prinzmetal's angina. It mostly had been a diagnosis of exclusion, which means you diagnose somebody objectively as having angina, and then you diagnose somebody objectively as not having coronary artery disease or atherosclerotic coronary artery disease, and that's how you label them as Prinzmetal angina. There are invasive tests that one can do, where during the time of angiogram, we can do vasodilator studies, or we can do stimulation studies with acetylcholine or papaverine and whatnot. In the modern era, nobody does it. We just establish angina diagnosis, and we establish there is no atherosclerotic heart disease, and we label them as Prinzmetal angina. That is how the clinical practice is done. But for the diagnosis sake, it can be done in the cath lab. I have never done it myself, and I don't suggest anybody to do it. And the reason why is because they can often get into refractory vasospasm of the coronaries, and that can actually precipitate myocardial infarction. Santosh writes that DTS is used to predict 5-year mortality. Yes, Santosh, this is what I was trying to answer that. But because Chandramukhi madam was here, I was hoping if she could give us a more detailed answer on that. Because out of all of us, I believe she is most equipped. She had been dealing with this pretty much on a daily basis, versus we look at it from the clinical standpoint. So that is the overall idea that we are talking about. I hope the idea of differentiating stable versus unstable syndrome that becomes very clear in today's discussion. I will tell you what I did for this patient, and then we have 5 more minutes to spend if we want to discuss more about this particular topic. So I ordered a high sensitivity troponin on her, along with other routine investigations like TSH and A1C and a hemogram and a renal function, which were routine for me. I did order a lipid profile on her. I did not order HSCRP because I was determined to exclude coronary artery disease on her. So what I did was I ordered a high sensitivity troponin with the idea that if the troponin comes undetectable or completely normal, then I will subject her for a CT coronary angiogram. And if her high sensitivity troponin would be anything touching abnormal, then I would subject her for an invasive angiogram. I did not want to label her as non-cardiac pain and would let her go at this time, because she comes from far off, and her new onset symptom definitely is worrisome enough that we should do something about her case. I also want to highlight this concept which is there in every medicine aspect, that is called Bayesian theory of conditional probability. What that essentially means is whenever we are looking at a test which increases or decreases our pre-test versus post-test probability of a disease, we look at how much the test adds incremental value. I'll give you an example. Let's say a stress test, a TMT in this case, has a 3 times incremental value, or adds 3 times incremental value to a post-test probability of a patient. What does that mean is, if you have a patient with a pre-test probability of coronary artery disease of 3%, let's say, I'm just giving an example of 3%. If that patient gets a positive stress test, TMT in this case, then your post-test probability becomes 9%. From 3%, it went up to 9% because you have got a test which has got a 3 times discriminating function. That is the conditional probability you are talking about, where a 3% pre-test probability increases to 9% by a positive stress test. Versus if the stress test is negative, then that because of that same 3 times incremental value, your post-test probability goes down from 3% to 1%. So if you do a low impact test in a low pre-test probability patient, then even if the test is positive, your post-test probability never becomes a high probability. You still hover around within the low risk itself. I hope with the audio, without showing you the actual pictures, I hope I'm able to make any sense that if we do tests of low impact in a low risk individual or a low pre-test probability individual, then even our post-test probability with a positive test is not that much, versus a negative test certainly has got very high differentiating power. I hope it makes sense as I'm talking. If not, then maybe I'll try to explain it again. So in these kind of patients who are indeed low risk, when we want to diagnose coronary artery disease, we should do a test which has got a high discriminating power, like a CT or an invasive angiogram, or a stress with the imaging, as compared to a regular treadmill test. Santosh, you have any questions or comment?
Good evening, sir. Sir, I want to share one experience of patient, 50 to 55-year-old female who was hypertensive, non-diabetic. She had a typical angina. Whenever she used to visit the clinic, by that time her chest pain used to subside. Each time ECG was normal. But at one point when her active chest pain was going, then she took a ECG which was suggestive of typical left main profile. And angio was done, which was suggestive of ostial left main 80% stenosis. So if a patient comes with a typical angina when the chest pain is already relieved, when we take ECG, often we find a normal ECG. How safe it is to subject this patient for stress test?
Santosh, this is exactly what Somaraju sir was mentioning, that, if the chest pain syndrome has unstable characteristics, and unstable characteristics are what? Coming at an unpredictable time, coming at rest, coming, like in this case, at sleep. If chest pains have unstable characters, then I find it difficult to subject them for a stress test. Then in these cases, a non-stress modality is a better option, be it a CT scan or for that matter, be it an adenosine test, but subjecting them to stress either with dobutamine or even physiological stress at times becomes very difficult if you have unstable components. If the same patient was coming to you with symptoms which were very clearly stable symptoms, and I hope I'm able to make this difference between stable syndrome versus unstable syndrome. If they come with stable syndrome for most part, then really you would be okay putting them on a stress test. ECGs would definitely change before the patient actually has a MI on your treadmill. For most part, I think you'll be fine. Unstable syndromes, I hesitate to put them on treadmill. I hope that kind of answers the question that you are trying.
Yes, yes, sir. Yes, sir.
That is why when the patient comes to us and chest pain is negative, a normal ECG does not conclusively rule out that they have coronary artery disease in that regard. Chandramukhi ma'am, you had something to add?
Regarding this Duke's treadmill test score, like it takes into consideration the duration of the exercise, the ST segment changes during the exercise, and the symptoms like angina. So this score, like if it is more than 5, then there is a very low risk that this patient will be having coronary artery disease. And if it is negative, like you said, the more negative the score, the more likelihood that the patient will be having coronary artery disease. So if the score is more than -10, that indicates a very high risk patient.
Ma'am, do we routinely report DTS in our treadmill?
No, routinely we are not mentioning the score, but if there are characteristics like strongly positive test, then we indicate that the test is strongly positive depending on the ST segment deviation, the time at which the patient developed the symptoms, like the stage, and also the amount of the ST segment depressions and the symptoms also, taking into consideration all three. We report it as strongly positive, but routinely we are not giving the score.
Perfect. Thank you so much, ma'am. And to complete the answer, I think not just cardiologists, but even physicians, it's very easy to calculate Duke treadmill score. You really just have to look at how many minutes they walked, not the METs, but the minutes, and then whether they had angina or not, and what was the total ST changes. And you can very easily do a back of the envelope calculation of DTS. And I certainly consider DTS very relevant if it is more negative than -10. So if a person has got -12, -15, that's a very high risk predictor. And these patients have got very high event rate over the next 1 year or so. So these patients, they should be investigated sooner than later. I'm going to read out a few of the comments from the chat box, and then we can close after that unless anybody has got any questions. So Rahul writes, water as a relieving factor, any significance in differential diagnosis? Rahul, I hear you what you are saying. Chest pain should not resolve with water if it is cardiac in origin. But we have to use patient's history with a pinch of salt. Any one of us who, if wakes up at night and has got some chest discomfort, they will go and get themselves, they will go and fetch themselves some water. That's just a normal human behavior. And if even an angina pain has to resolve within 5-10 minutes, then it is very easy to corroborate what you did, whether you had a water, or for that matter, she could very well have had tea or even beer, doesn't really matter. That pain would have subsided within 5-10 minutes as well. So I completely hear you that pain getting better with water points against cardiac in origin. But it could just be a temporal association. It may not be a causation in any form. Salma asks, any role of calcium score for risk analysis? So Salma, this is second point of contention that I have with the guidelines. Calcium score is a risk parameter or a risk identifying tool. For an asymptomatic individual, we use calcium score quite routinely. Role of calcium score in a patient who has chest pain. So using calcium score as a chest pain evaluation tool, this is something I never could come to terms with it. I cannot imagine how calcium score can be used as a tool for chest pain evaluation. While I have a very strong feeling, guidelines say the other way. Guidelines do advocate using calcium score to evaluate chest pain in low risk individuals. And again, for them, the low risk means less than 15%. I do not agree to that. I personally do not think that calcium score should be used for chest pain evaluation. Definitely in an asymptomatic individual, to predict future risk, just like heart score that we have discussed previously, or ASCVD score, or Framingham score, or pool cohort score, or there are so many scores, there are so many risk scores which are there. For an asymptomatic individual to estimate their 10-year risk of ASCVD event, calcium score is absolutely relevant. Dr. Vamshi Krishna asks, if recent chest pain, how many days do we wait for TMT? Dr. Vamsi, I don't think I have a good answer for that. If you will ask my opinion, I would say if you were dealing with an unstable cardiac syndrome, and if you did not evaluate with a CT or an invasive angio, then I would wait for a month before I put them on a treadmill. That is what I would do. I don't have a scientific data to back it up. But truly speaking, I wouldn't wait for a month anyway. If I believe a patient has unstable syndrome, I would evaluate them immediately. I wouldn't wait for a month. That's like a natural selection, right? If this patient had a bad coronary syndrome, then within a month, there is a very high chance they would have a repeat unstable syndrome, or God forbid, even an MI. And the fact that the patient waited till a month and not having any cardiac event, that itself tells you that most likely this was not a cardiac event. So there is a natural selection in place. I wouldn't wait for a month just to do a TMT. I will do a cardiac evaluation before that. So in this particular patient, I did order HS troponin. HS troponin came negative. Negative means undetectable, less than 2.5. I immediately ordered a CT coronary in her, and CT coronary came out negative. All of this was done within 4 hours of her hitting my clinic. I was able to send her home by 6 o'clock in the evening with an absolute confidence that she does not have any cardiac illness. I did put her on symptomatic management with mostly drugs, mostly geared towards GI symptoms. And I told her that if she continues to have symptoms, then we will do a thorough GI evaluation, like what Shankar sir suggested in terms of endoscopy and whatnot. This is what I did.
Anoop, can I interrupt you here?
Yes, sir, please.
Remember, you said she's a vegetarian. You must go out of your way to check B12 levels.
Yes, sir, I did that.
Yeah, thank you.
Yeah. So I did do, thankfully, she was very forthcoming in terms of me doing whatever I thought was appropriate. And because whenever a patient surrenders to me to do whatever I want, whatever I think is appropriate, then the responsibility is very high, because now I really don't want to overdo something. And this is my biggest concern as a cardiologist, that when I am overdoing something, when I was ordering CT, when I was ordering these vitamin levels, I hesitated just for a second, because I questioned myself, am I overdoing this? Her symptoms to me, as I said, sounded like gastric reflux. But then I wanted to give her the confidence so that by the time she leaves my office, she needs to be absolutely confident she does not have any coronary syndrome. So I did order all of this. And thankfully, all of her investigations, literally every single thing came out normal. I'm sure she's more confident of her human body, but certainly that is after a lot of testing over 4 or 5 hours of her being in the hospital. Whether I overdid something, I don't know. I personally want to believe that I didn't over investigated her, but that's open to discussion. And that was one of the reasons why I brought up today's discussion. Anybody has got any other questions or comments? Anything they struggle with evaluating chest pain that we can answer? We are 8 minutes post our scheduled time. And if not, or while you gather your thought, I'll ask Praneeth to give his summary statement about today's discussion and points that we learned.
Yeah, no. So as you said, chest pain is something which is as basic and equally can get as complicated as can be. And while we are evaluating a patient with chest pain, we have to become something like Sherlock Holmes and try to find out what is the problem. And no matter how hard you put it, sometimes, as BSSR was telling, you can still go wrong. The person, the physician has the is the most important person to take a call with the way he takes the history and evaluates the patient. He is the most important person to know or make a better judgment of what is going on, understanding that there can be issues. So getting the patient into confidence on understand or explaining them about this possibilities or inherent fallacies that we have in evaluation of chest pain, and relying on few investigation, also understanding that they can be normal at times and still doesn't rule out the problem. And when in doubt, always keeping the patient in the loop and calling for frequent visits or educating them about not ignoring the symptoms if they do recur, and a bit of education on evaluating the chest pain by themselves. And maybe at times, once in a while, overdoing also is worth it, where missing an event will be more costly versus over investigating in few select patients. So definitely a challenging thing, and it's always learning when we talk about chest pain evaluation in a patient.
Thank you, Praneeth. And before I close, I want to ask this question again, and this time I'll ask Somaraju sir directly. Sir, what is your opinion? Am I overreading these guidelines? Low pretest probability being 15%. Is it something that we as a cardiologist should accept this number? Or am I overreading the guidelines that are putting up? Somaraju sir, what is your opinion on this?
When you are dealing with individual patients, guidelines, so-called evidence-based medicine is not directly applicable. You have to individualize and you have to do what is best in the best interest of the patient. And also when, depending upon, you already highlighted, you are a specialist, not a general practitioner. Patients also choose to go to somebody like a specialist like you because they may not tell you everything, but at least they are afraid of something, and they may underplay sometimes. But the fact that they came to you is another, I would almost say, another clue that there may be something wrong. The patient may not be telling you everything. Keep always that in mind when you are practicing in a tertiary care hospital and patients decide to come to you because they felt something different. So on this, I have to add, guidelines will be misleading, evidence-based medicine will be misleading. And what time the patient came to you also matters. Like when they came to you on a Sunday evening, to emergency room or middle of the night or early hours of the say day, whatever it is, unusual times when they come to you, when you're in emergency room or somewhere, always respect that time. Nocturnal pains particularly have serious significance. Whether it is nocturnal headache, or nocturnal chest pain, nocturnal abdominal pain, do respect it. It's not essential to make a definitive diagnosis, but it's important to be safe. Thank you.
Thank you so much, sir. I remember the very, very basic notion that we tell our residents, and we also follow the same thing, that if somebody came at 2 o'clock at night for chest pain evaluation, don't discharge them. They deserve to be observed at least for some time, because if they decided to come at 2 o'clock at night, they find something is wrong, and you just have to respect the human body in that regard. I will close with one last thing.
Anoop, I just wanted to say something. Sorry,
yes.
I forgot to tell.
Yes.
Somebody asked about calcium score. Calcium score has the same value as gray hair. Don't overread it. Thank you.
Sir, we have heard this from you multiple times. I think the point is very, very well valid. Don't do calcium score in a 70-year-old. That's the whole idea behind. You will find calcium there. That is just not going to be a good diagnostic tool. But I do want to finish with this last thing, which I again take it very dear to me. In the last few months or a year or so, we have heard a lot of unexpected demises which came in the social media regarding young individuals who were getting cardiac arrest, most likely related to MI. And sometimes there were scenarios where these people, they actually got evaluated. The so-called evaluation was done and was found normal beforehand, maybe like a week ago or a month ago or something like that. I remember there was one medical professional, I believe in Hyderabad itself, who had an event, and we were discussing how he or she, I can't remember, had the evaluation done beforehand. This is where I want to highlight that for a chest pain evaluation, you cannot stop at ECG and echo. What Santosh mentioned and what we have been discussing, it is very easy for us to just look at ECG and echo, say everything is normal and call it a day. Because by the time patient got ECG and echo done, that unstable syndrome probably settled for the time being, and it will reflect as a normal, it will register a normal ECG and may not have an echo finding unless an acute MI has actually occurred. So while you might hear that the previous evaluation was normal, it is pertinent for us to look at what was a part of the evaluation. If it was only ECG and echo, then we are grossly underdiagnosing a lot of these chest pain syndromes. Because if a patient hits a cardiologist office, by the time they leave, they need to be absolutely confident they don't have the disease with them. I hope with that I was able to justify today's topic that we're discussing. A chest pain discussion cannot happen in 1 hour, but at least I tried to bring the salient points across. Thank you all for being with us, and we can continue this discussion on the WhatsApp group, which we have with the name the Weekly Huddle. And I urge you all to join there, where we can discuss offline about all the topics that we discuss on the huddle. I'll see you all next Wednesday at 7 o'clock with a new topic. I thank all of you for being here with me and being here truly speaking for 80 some episodes with us. Thank you all. Good night. We'll see you next Wednesday.